It's affecting male and female at the same rate and the age of 30 to 50. However, it can occur at any age. Therefore, we have pediatric psoriatic arthritis, and it can occur even in the elderly. The majority of patients will have skin psoriasis preceding the psoriatic arthritis. However, we might diagnose with PSA even without the appearance of the skin, and in some few conditions they present together at the same time. So the psoriatic arthritis is a very heterogeneous disease. It has multiple domains. That's making the management of psoriatic arthritis is relatively complicated. And therefore, we have to pay attention when we have patients with psoriatic arthritis. It's not only the skin and joint, but it also involves the axial, which is the back pain. And previously we thought it's rare. However, nowadays we recognize it can go from 40 up to 70% of patients. It depends on the duration of the disease, as well as the enthesitis, dactylitis, and nail. And therefore, this is a very heterogeneous disorder. You have to evaluate all these clinical manifestations when you have a patient with psoriatic arthritis. Now, I'm going to talk about our Saudi consensus guidelines, how we did it. So first of all, in the methods, we established a committee. It consisted of 6 rheumatologists, 2 dermatologists, and 5 pharmacists. We had 5 workshops. It's held between December 2021 and March 2022. And the objective was to discuss the importance of the disease, why we need to establish these guidelines, and what are the first lines for the treatment of patients with psoriatic arthritis. And therefore, we have to depend on the background guidelines. We used GRABA, EULAR, and British Society of Rheumatology guidelines, and I'm going to touch the GRABA and EULAR quickly. So what is the EULAR recommendation? This is the EULAR recommendation 2020, which was used at that time of establishing our guidelines. As you see in the EULAR guidelines for treatment of PSA, they used the biological therapy, either TNF, IL-17, or IL-12/23. But it's very important to stop here. I put the stop sign there. The reason behind that, this is before the approval of IL-23 for treatment of PSA. And therefore, we have to review also the data about the IL-23 in psoriatic arthritis. The other thing that the JAK inhibitors, they considered it after failure of the biological therapy, and I'm gonna touch it during my talk and explain why we also consider it after the biological therapy. Apremilast, you are not going to see it in the guidelines as the treatment algorithm. The reason why, because of the red circle, it's considered only for the mild disease. So if you look to the ACR20, which means 20% improvement in clinical features as well as the inflammatory marker, it's reported only in 40%. While in anti-TNF, it's ranging between 52 to 58, IL-17 ranging between 60 to 70%. And therefore, apremilast is considered only for mild cases, and that's why we don't consider it in the treatment algorithm. This is the most recent GRABA recommendation. And the GRABA recommendation, as you see here, this is useful, but again, it doesn't explain the struggles in our daily practice, because as a treating consultant, as the clinical pharmacist, all the biological therapy are considered as first line of therapy. And therefore, which one you should choose to treat your patient. That's why I recommend all the healthcare providers to review the literature, review the study, see which drug that you could use it as first line and the second line, and so on. Because the guidelines, it's helpful if you are not specialized. If you are specialized, everyone could be used as first line of therapy. So back to our Saudi guidelines, this is the eligibility criteria. And now you have a patient with peripheral arthritis, they have to fail at least 1 DMARD. And the DMARD, which are the disease-modifying anti-rheumatic drugs. And this is a very debatable area. Is methotrexate considered DMARD in PSA or no? We could discuss it later. But we request every single patient, before jumping to biological therapy, they should be started on the DMARD, or let us say the immunosuppressive therapy, possibly to be DMARD like methotrexate. If you have axial patients or enthesitis and dactylitis where DMARD, we know it does not work in this condition, you just try NSAID for 4 weeks. If it doesn't work, you go immediately to the biological therapy. So if you have axial PSA, enthesitis, dactylitis, you don't need to mandate using of methotrexate or leflunomide. You go directly to the biological therapy. And then your patient started the treatment. What is the goal that you are looking for when you start the treatment before switching or discontinuing or tapering the medication? We have to have the goal. The goal for peripheral arthritis is DAPSA, and I'm going to explain what does it mean in a few minutes. But DAPSA is a score system that's used for PSA, and if you say remission, that means it's less than 4. If you say low disease activity is less than 15, more than 4 and less than 15. And above 15, it's considered moderate disease activity. If you are having a patient with axial PSA in registry or in real life, we are going to use the ASDAS score, and ASDAS score, the remission is less than 1.3, and the low disease activity is less than 2.1. And again, don't worry, I'm going to show it to you in a few minutes. If you have enthesitis and dactylitis, there are assessment tools, but this is not used practically, and therefore we leave it for the physician's evaluation or apply the MDA, the minimal disease activity, and again, I'm going to show it to you in a few minutes. Now, your patient is eligible for the biological therapy. Every single patient who's going to start biological therapy has to be screened by doing these labs test or investigation. CBC, liver function test, renal function test, hepatitis B, C, HIV are mandatory before starting any biological therapy, and quantiferon or IGRA, it depends on what are you calling it, which is the gold tuberculin for the TB test, or TST, the tuberculin skin test. However, if you have quantiferon, please use quantiferon because TB is endemic in Saudi Arabia. If you are going to interpret the TST, it depends whether your patient is immunosuppressed or immunocompetent, whether he is on steroid or not, and therefore we are highly recommended IGRA if it's available in your hospital. If you are doing IGRA or tuberculin, that's enough. You could escape chest X-ray, but if you are doing the BBD or TST, you have to do the chest X-ray. If you decide to start your patient in JAK inhibitors, please do lipid profile before starting the JAK inhibitors as baseline, and it's recommended to do it as follow-up at 3 and 6 months, and then every 6 months to monitor the lipid abnormalities in a patient who were given JAK inhibitors. This is how to monitor the patient and what we mean by DAPSA. DAPSA, it's a scoring system. You will see the score in the registry. So just look to the registry and look to the score, whether less than 4, less than 15, or above than 15, where the patient is still having an active disease, whether it's moderate or severe. MDA, it's very tough to be achieved, but we wish to achieve MDA in our patient, which is the minimal disease activity, where there is the tender joints are 1 or less, the swollen joints are 1 or less, and as you see, the BASI score is 1 or less. The body surface area involvement in skin psoriasis or PSO is less than 3, and so on. It depends on multiple scoring system. This is the guidelines that you will see it in the publications and in the MOH documents. I wanted to highlight a few important points here. First of all, if you decide to start non-steroidal, please don't exceed 4 weeks. Previously, we said it's 12 weeks. Nowadays, 4 weeks is enough. No response, no response. Partial response, go immediately to the second line. And then when the patient failed non-steroidal, if you want to start it, however, you can go directly to the DMARD, wait for 3 months. If no improvement, this is the indication for biological therapy. What is the first line in Saudi consensus guidelines for peripheral arthritis is the IL-17 inhibitors. And I'm going to show it to you in a few minutes why we used IL-17. If we have dactylitis, enthesitis, axial, don't try DMARD. NSAID, 4 weeks, no response, biological therapy. First line of therapy is IL-17 inhibitors. Now, for dactylitis and enthesitis failed, the second line is IL-23 inhibitors, And the reason behind that, because IL-23 is the major cytokines for enthesial inflammation. And in axial, we choose IL-17 inhibitors. The reason behind that, the only drug that have RCTs, randomized controlled trial, we know all the biological effective could control the pain with axial PSA, but the only drugs that have RCT is the Cosentyx, which is IL-17 inhibitor. If it's failed at this moment, go to the TNF inhibitors. We still have an ongoing IL-23 trials for axial PSA. Till we get the result, we cannot put it as second line of therapy. And then if it's failed, you can go to each one of the biological therapy. For peripheral, if it's failed IL-17, you can go to the JAK inhibitors, which are oral medications and effective in a patient with peripheral therapy or with peripheral arthritis. The second thing that's highlighted in red is the DMARD. The methotrexate is the most commonly used in treatment of PSA, and it's our friend. We love it. We like it. It is safe. Okay, so please don't use it as the cancer treatment. This is an immunosuppressive therapy, and the dose less than 25. It doesn't play a lot of side effects. So typically we use methotrexate, and please, if you start methotrexate, don't start 10. Go immediately to 15 milligram, 3 months, no response, stop it. And all the biological therapy that's approved for PSA could work effectively with or without methotrexate with the same degree of the response. Now, this is a very important slide, and this is, we know it from head-to-head trials for the IL-17 inhibitors versus the TNF, and that's why we choose IL-17 as first line of therapy. If you look to the rheumatological manifestation or arthritic manifestation, they are almost similar to the adalimumab. They are non-inferior to the anti-TNF. But again, as I said in the first slide, PSA is not only joint, it's joint, skin, dactylitis, enthesitis. And therefore we said, okay, they are non-inferior. What's about the other clinical manifestations of PSA? We look to the skin, and then when we lump the BASI 100 and ACR 50 simultaneously, this is for the Cosentyx. You look here, the superiority of Cosentyx as compared to the adalimumab. And we look to the other agent, which is the ixekizumab. And again, they prove the similar superiority when they look to the BASI 100 and ACR 50 as compared to the adalimumab. And therefore, I have a patient with a skin and joint, which is the most common situation in more than 90% of our patients. And therefore, IL-17, when you talk about the composite endpoints, they are superior to the anti-TNF agents. And that's why we in Saudi Arabia choose IL-17 to be the first line of therapy in treatment of PSA. The other good points for the IL-17 is the quick onset of the action. Within 1 week, you will see the response. While when we look to the anti-interleukin 23, you need to wait for 2 to 4 weeks to see the response. IL-17, 1 week, you will see the response. So we have drugs that have a quick onset of the action, and we have the drugs that's superior to the anti-TNF agents when we talk about skin as well as the joint manifestations. Now we consider JAK. This is discussed in 3rd June, few days ago in EULAR in Milan, and I brought it to you just to draw your attention that we in Saudi Arabia, preceding EULAR, which is the largest rheumatological society in Europe, in considering JAK as second line of therapy. So yeah, we need to congratulate the team. They put the JAK as second line. The reason behind that, it's not about the efficacy, it's about the safety. And therefore, we are in similar line with the EULAR in considering JAK as second line of therapy in treatment of PSA patients. Quick touch to the IL-17, the only agent that they have the RCT's randomized controlled trial to treat the PSA, axial PSA, which again is a different from ankylosing spondylitis, is the IL-17 and Cosentyx. They show that it's effective. Whatever you are using the methodology, this is mainly toward the research, but to draw your attention, whatever you are looking, whether it is the multiple imputation, NRI observed, it shows the superiority of the Cosentyx versus the placebo. And as you see here, the ASAS-20 was achieved in more than 60% of patients who received Cosentyx. Again, back to the PSA, the first slide. It's not only the joint, it's not only the skin. We have to think about the other manifestation. And we found the cousin ticks, which is IL-17, it caused resolution of enthesitis in 83% of patients. That's why, again, we consider IL-17 first line of therapy in patients with enthesitis or dactylitis. When we look to the dactylitis in a patient with cousin ticks, almost at 5 years, 94% they will have complete resolution of dactylitis. We don't have similar efficacy with anti-TNF agents. Again, similar response has been demonstrated in the other agents of IL-17, which is ixekizumab in both Spirit P1, Spirit P2, whether biological naive or biological failure patients. They responded very well, and this is for the lead enthesitis and lead dactylitis index. As you see here, a large number of patients responding to the ixekizumab, which is IL-17, whether they are naive or biological failure. Then the enthesitis and dactylitis for gozelikomab, which is IL-23. This is the second line. Now we said, okay, we need to think about the second line. Shall we put anti-TNF or IL-23 or JAK inhibitors? Pathophysiologically, IL-23 is the most important cytokines for dactylitis and enthesitis. When we look to the dactylitis and enthesitis in gozelikomab, and look here, the response is dramatic, is excellent, whether we are looking for gozelikomab every 4 weeks or every 8 weeks. And Cosmos trial, this is even after failure of the previous biological agents. And at that time, the most common biological agent is the anti-TNF agents. And therefore, even if you have a failure, more than 50% of your patients, more than 50, around 60%, they will respond to the gozelikomab, which is the IL-23. And that's why we consider IL-23 second line of therapy in a patient with enthesitis or dactylitis. And then the JAK inhibitors, we consider them second line in PSA. I leave PSA for our colleagues in dermatology because for tofacitinib, the result was not dramatic for the skin point of view, but for the arthritis, remember when we say the anti-TNF, it's ranging about 52 to 58. For the tofa, it's again 52 in biological naive and 50 in a biological exposed patients. And therefore, they are good medications, oral, but it's not as dramatic response as expected in IL-17. The second JAK inhibitors is UBA, which has a dramatic response in a patient with either biological naive or biological failure. And upadacitinib, yes, there is no head-to-head comparison with tofa, but numerically it was much higher than tofacitinib in response in the patient with PSA. So they are good medication, but we have to pay attention to the safety. Now, what's about the special condition in Saudi guidelines? One is the infection. And I would say that if you would like to choose the most safest biological agents for PSA is IL-23. IL-23 inhibitors, they have a very, very excellent safety profile. There was zero TB in all their trial. There was zero TB, zero opportunistic infection, and therefore they are very safe in case of patient with recurrent infection or they are at high risk of infection. Abremilast could be used, but again, keeping in your mind, this is preserved for mild conditions. If we have a patient with latent TB, please avoid anti-TNF. If you are going to use anti-TNF, they have to be treated at least 1 month before the starting of anti-TNF. If you have to use anti-TNF, the safest one is the receptor blockers, the Enbrel, but we have safer agents like IL-17 and IL-23 inhibitors are safer in these conditions, and I wouldn't use anti-TNF unless I have to, such in conditions of uveitis. Hepatitis B, please don't use any biological agents unless the patient already started on anti-hepatitis B treatment. Otherwise, please avoid biological agents. This is not true in Hep C. In Hep C, actually, anti-TNF are very useful in such patients. And therefore, if you have Hep C, just consult hepatologist for the safety profile aspects and go ahead and start anti-TNF. It looks like IL-12, 23 safe in a patient with hepatitis C. We don't have data about IL-17 and IL-23. still they are relatively new toward this population of the patients, and therefore you should be careful if you decide to use these agents. HIV, I personally recommend all of you don't start anything in this group of patients unless you consult HIV expert infectious disease consultant, because this is a syndrome rather than disease. It has a multiple presentation, different clinical response to the treatment. So please consult ID, preferably to be HIV specialized before starting any treatment. Biological therapy, it's better to avoid a biological therapy in a patient with an ongoing malignancy. However, if you have a patient with cancer within 3 years or more, go ahead and start any biological agents. If a patient is still having malignancy, probably the safest one is rituximab. However, rituximab, we have no data about rituximab in PSA. Cardiovascular disease, just to draw your attention to two important points. JAK inhibitors, please don't use it in a patient who are at high risk to develop coronary artery disease or heart disease. The other thing, if you have a patient with congestive heart failure, class 3 and 4, avoid anti-TNF agents. Now, using of biological agent does not increase the risk of or side effect of cardiovascular disease, but if you have these underlying conditions, you have to be very careful. Respiratory disease, in general, biological agents could be used. There are some concern about abatacept, but anyway, it's not in the algorithm of the PSA. Uveitis, the only approved and effective agents for uveitis are monoclonal anti-TNF agents. Unfortunately, we don't have any data about the others. We have data that uveitis didn't aggravate or was not aggravated by IL-17 or IL-23. Demyelinating disorder, avoid anti-TNF at all. Family history, again, avoid anti-TNF agents. Go ahead and use IL-17. We have actually case series that's supporting IL-17 in a patient with multiple sclerosis. Data are very limited about IL-23 as well as JAK inhibitors in this condition. Connective tissue disease, avoid TNF. Avoid TNF in anyone who have a history of connective tissue disease. Anyone with positive anti-double strand DNA, I consider him or her contraindicated to start anti-TNF. ANA is questionable, but anti-DNA is please avoid anti-TNF. In this condition, the best agent is IL-12, 23, Stelara, and we have few cases already on this treatment, and we have a SLE. Obesity, we have an evidence-based study that showed obesity reduced the drug survival rate, reduced the response to the anti-TNF agents, and therefore, if you have obese patients in the clinic, please try not to use anti-TNF unless you have to. Surgery, think about stopping the medication, 3 to 5 half-life before the surgery. You could resume it once the wound is clean. You go immediately and you resume the medication. IBD, avoid, if you have active, avoid IL-17 inhibitors. However, if it's a remission, you could use it, but it's better to use the other agents like the anti-TNF. IL-12, 23 are approved, and recently IL-23 comes in the line and approved for the Crohn's disease and ulcerative colitis. So IBD, you could use monoclonal TNF inhibitors, IL-12, 23, and now IL-23, and also coming the JAK inhibitors in the future. Pregnancy, the safest agent, evidence-based, is certolizumab Cimzia. However, you could use anti-TNF agents like Enbrel and adalimumab, provided that you're going to stop the monoclonal anti-TNF at week 32 or 33 of gestation. But we recommend certolizumab because there is a strong evidence that's supporting using it during the pregnancy. Now, I wouldn't talk a lot about the disease activity measures and scoring system, but it has been requested from me to present it and to be aware when you see it in the registry. As you see, different clinical manifestations, different scoring system, different assessment tools, none of them assist behind or against each other, so you can use any one of them. But what we are going to use and why we are going to use the assessment tools in the registry. First of all the studies will publish ACR 20, 20%, 50, 50%, 70, 70%. This is the inclusion in the ACR, the tender swollen joints, and also the assessment of the pain, HAC, and the inflammatory markers. But is this practical? Stop. This is not practical. We cannot use it in the clinic. That's why you will not see it in the registry, in Saudi registry of PSA. DAS 28, if you look to the STELARA study, Summit 1 and Summit 2, they report DAS 28. But DAS 28 is designed for rheumatoid arthritis, not for psoriatic arthritis. It assists only 28 joints, while in psoriatic arthritis is 68 joints. So again, we don't use it. Please don't depend on any recent study who evaluate DAS 28, and you are not going to see it in the registry of Saudi PSA. This is the most important one, DAPSA, which is very easy to be used. It assists all the involved joint in psoriasis and psoriatic arthritis, and also it assists the other manifestations of the pain. It looks complicated, but believe me, it's very easy. This is in a smartphone. We are using it in the clinic. It does not consume more than 1 minute. You just look to the tender and swollen joint count, and you ask about the pain assessment, global assessment, and you report the CRB. You click enter, your smartphone will calculate the score, and you go ahead and put the score in the registry in the future. Is it good assessment tools? Still, there are limitations of this. It does not assist the enthesitis. It does not assist the skin, and therefore it does not assist the axial. And we said it can go up to 50, 60%. It depends on the patient's age, the patient disease duration of psoriasis and psoriatic arthritis. And therefore, this is probably the most useful one in real life, but keep in your mind, this is not evaluating everything. Therefore, if you have a patient outside DAPSA scoring system, go ahead and use MDA, and that's why we include MDA in Saudi PSA registry, and Dr. Naif, I think, gonna to touch it in more details. This is how it looks like, the terminology, MDA, the minimal disease activity. We wish, ندعو Allah, and we have VLDA, very low disease activity, but this is very tough and difficult to be achieved. DAPSA and the PSA disease activity score, PASDAS, if you are going to see it in any study. If you have a patient with back pain in the registry, if you are a clinical pharmacist or you are involved in evaluation of the drugs or study or whatever, we are going to use the ASDAS. The ASDAS, it has scores. We are looking to 1.3 or less, which means remission, or at least 2.1, which low disease activity. Again, you think it's difficult, but in real life, it's not difficult. It can be assessed very easy in the clinic, in the smartphone, a SaaS application, download it. It comes like this: total back pain, 0 to 10, and then peripheral joint pain, duration of morning stiffness, patient global CRB. Just click enter. Your smartphone will calculate it and will give you the score, and you go and record the score in the registry. For dactylitis, this is the dactylometer, but unfortunately, I don't see it in Saudi Arabia, and I don't think it's available or no. When I came back from the fellowship 2013, I was looking to it. I didn't find it in Saudi Arabia. So it's easy, but it's not available. So we cannot request in the registry. Asking some people to do something is not available. That's why we leave it to the physician assessment, whether it's improved or no. This is again the enthesitis. If you look to the enthesitis, it's different sites, different scores. People, they might use lead, which is very simple because this is the simplest one, 6 sites. But you might see a MACES, which is around 13 sites, or Spark, which is 18 sites. Which one is better? Most of the studies used leads because it's simple. This is the simplest one. Again, in real life, we don't use it, so please don't complicate our life. Ask only the physician global assessment for these clinical manifestations. So in conclusion, this is my last slide. Psoriatic arthritis is not simple disease. It's not peripheral arthritis. It's a peripheral arthritis, axial. It has also extra-articular manifestations, skin psoriasis, enthesitis, dactylitis, uveitis, IBD. So you have to think about all these domains when you evaluate the patient. That's why recently we increased the domains from 6 to 8. We include uveitis and IBD. Think about comorbidities. The most important one is obesity and cardiovascular disease. And the reason behind that is the medication-wise, cardiovascular, JAK, obesity, anti-TNF agents. Think about the early diagnosis. We stress in early diagnosis because we aim to catch up the patient within 6 months. Look to that side, 6 months enough to develop the destruction, enough to develop the sacroiliitis, enough to develop the disability. Thank you very much.